Professor Kim graduated from the Sungkyunkwan University in 2004, and after that, she served as the assistant professor at Dongtan St. Mary's Hospital, and currently she is working at the Samsung Medical Center. So please, Dr. Kim, thank you for your kind introduction. I am working at the Samsung Medical Center at Seoul, and today I'd like to talk about the radiation after breast conserving surgery. I'd like to talk about basically four areas or four topics. One is that why the radiotherapy is important after the breast conserving surgery. And actually, patients have a lot of concern about the radiotherapy because there are unfounded misbelief about the risk of the radiotherapy. So I'd like to talk about the process of the radiotherapy, so what kind of the process the patient goes through. And with the patients who underwent BCS, how we at the radio-oncology decide the scope of the radiotherapy and the dose. And I'd like to also talk about the complication after radiotherapy. And the third presenter of this session will be delineating further on the management of the complications. So I will briefly touch upon what kind of the complication can occur after radiotherapy. After the breast conserving survey, the patients go through radiotherapy. And why do we have that? As you can see from the picture, in the past, there was mostly the mastectomy. However, with a lot of studies and trials, the partial mastectomy and plus the whole breast radiotherapy proved to deliver equivalent outcome to the mastectomy. So more recently, many patients are detected in the early stage, so usually they go through the BCS. And for example, in 2017, 67% of the breast cancer patients in Korea underwent BCS. It means that there are many patients who undergo the radiotherapy. So every year we see many patients are receiving radiotherapy after the BCS. And after that, after the BCS, why do we have to have the radiotherapy? Surgeons are very good at delivering good results with the surgery, and therefore there is low risk of having the residual tumor. But even after that, with the microscopy, there can be some remnant, very small, the cancerous tissue. So in that case, we do some radiotherapy over it. So what would be the mechanism of radiotherapy? The DNA of the malignant cell, which was exposed to the radiography, that is killed. So it can be harmed with the radiography here, X-ray, gamma ray. So this kind of the rays are used, but usually for X-ray, that is quite often used. You can think of it like the CT or X-ray for your chest, but there is one difference. For X-ray, for diagnostic purpose, they do not go penetrate into very deep into the body. It utilizes low dose. However, when it comes to the radiology onco, then the ray here can penetrate deeply into the body. So they are the same kind. However, when it comes to the energy level, they are different. The radiotherapy utilizes strong energy level irradiation. And one of the most frequently asked question is that if I receive the radiotherapy, other normal cells can be killed. they can be eradicated. So that's one of the concerns that patients have a lot. No, that's not the case. The DNA of the irradiated cell is attacked. However, there is a huge difference between the normal cell and the tumor cell. For tumor cells, once there is a damage on the DNA, it cannot be recovered that well. So that's the characteristics of the tumor cells. So if there is a irradiation over cells, the DNA of the tumor cells are just killed and eradicated. However, for the normal cells, those damages can be restored and recovered. So when we have the radiotherapy, the normal cells, some part can experience inflammation but can get better. So the tumor cells only are killed with the radiotherapy. So even if you have the radiotherapy, that does not mean that your normal cells are killed or damaged. Of course, they can experience some inflammatory responses, but they can come back. So what would be the roles of the radiotherapy? It is done to all the patients who went through the breast surgery. So there are many studies, but I'd like to share just one. The patients with BCS alone and patients with BCS plus radiotherapy, they are compared. Half of the patients experience, there is a half rate of the recurrence, and the survivor has been prolonged, and therefore the radiotherapy is a must in order to prolong the survival after BCS and reduce the local recurrence. And some patients say that because of the radiotherapy, I might be killed, but that's not the case. The radiotherapy does not deliver bad effects to your survivor. So after the BCS, the radiotherapy actually reduced the local recurrence rate and prolonged the survivor. So there is a strong evidence about that. So as you can see here, every other year, there is a committee where the relevant specialists come together to come up with the clinical practice guideline. It also recommends that we need to have the radiotherapy after the BCS, and that is also true by the equivalent committee in the U.S. So the post-lumpectomy adjuvant therapy, the radiotherapy is recommended as that. So when patients visit us, how we proceed with the radiotherapy. As you can see here, unlike the drug treatment, you just cannot have the radiotherapy right away. You have to see the doctors first, and then we have to discuss whether the radiotherapy needs to be done or not. So it requires the examination step, and then the patients, you know that there is a simulation of therapy. It's kind of drawing a picture or like the planning. And we have the CT equipment. So we take the CT. So you go through a lot of screenings and a lot of diagnosis. So you may complain that, do I have to take another CT imaging? But here it's different. It's not about the diagnosis, it is about the planning, the radiotherapy. So without the CT scanning or the CT imaging, we just cannot do the radiotherapy. So if you look at this is quite similar from the imaging department, but here we have the razor at both sides. And when we have the CT simulation, we see whether, where, on what location this razor can be radiated. The CT here has the razor, and within the radiotherapy room, we have the razor, the same one, so that we'd like to identify the location where the radiotherapy or the radiation can be made. So it's kind of drawing a picture on the body. So it may be a little bit different from one hospital to another, but this is how we do at our center. Here, this patient has to have the treatment on the left breast, but you can see the lines on both breasts. So sometimes patients say that, well, I have to treat only the left breast, not the right breast, but it is to have the balance, to check the balance. So it is it is to have more stabilized line on the diseased breast. And after taking the CT imaging, then we start to plan the radiotherapy. And it takes a bit different time. I mean, sometimes some hospitals takes just one day, or other hospitals may take a week. Sometimes we have to be more sophisticated about the planning. It can be delayed a little bit longer than a week, or sometimes that department has more patients. Well, it does not mean that your treatment will not that good, even if it takes longer than a week. So once we have the clear planning, then we can start the radiotherapy. Sometimes patients have the recurrence and they want to hurry up with the radiotherapy. So they want to have the radiotherapy as soon as possible. However, when it comes to the radiotherapy planning, it requires a lot of work and very sophisticated calculation. And the more sophisticated in the planning stage, it's better in terms of the outcome. So you don't have to worry about that. So making the plan for the radiotherapy, it's really important, as if the surgeons are planning for the surgery. So we have a lot of computers in the room, and we have to decide which part and from which angle do we have to irradiate or not. For this case, we need to irradiate on the right side of the breast. So we have to identify which area of this breast is most vulnerable or risky. So we call it as targeting. So we have to be very clear about the targeting, and we have to prevent the irradiation to be made into other organs like the liver and others. So we also plan for that. So it does not require the radiation oncologist. We also require other specialties in order to decide the right radiotherapy planning for a specific patient. And that's not end of the story. And we have to make it clear again whether it will work with the patient. So we do some computer simulation and do the calculation and check whether it is safe or not, and then starts the radiotherapy. In the radiotherapy room, as you can see here, it looks like a CT equipment. We prevent the wrong exposure to the radiology. So here you see different equipment. Maybe the picture is different because the equipment may look different. So here the patients can lie down, and then both sides, each side, as if you are taking the CT and X-ray. We also take CT or X-ray in order to double check the treatment plan. And we call it head. Here you see you will have the irradiation. It takes only like 1 or 2 minutes for the radiation. However, it takes more time because we need to set the equipment. So it takes about 10 minutes to 20 minutes in the room. And you can see that this is the small room. So if you move a bit on this table, it may be a bit risky for you. However, still, it is not hurting you and it is not risky. And it is quite safe. So it is really important for us to decide the extent of the radiotherapy, which area is more likely to have the recurrence. Like, although we have the tumor cell here only in breast, but still it may be there can be some possibility for recurrence in other sites. We have to predict it in doing the radiotherapy. So we checked the disease stage, and we have a kind of a consensus or accumulated knowledge about it. Sometimes patients ask, saying that, let's say I have a friend who has the same disease, but she underwent, actually she had a radiation all over the whole breast, but why not me? So it depends on the patients. For example, although you have only a small fraction of the residual tumor cell here, maybe there can be some molecular characteristics, and that means you need to have the radiation on other areas there. So we have to make a very detailed plan, and then we need to decide the extent of the radiotherapy. So when it comes to the extent of the radiotherapy, one type would be the whole breast. It has been quite long years for whole breast to be irradiated. Sometimes the patients complain that I have only a tumor on a spot, only a small area of the breast. Why do I have to whole breast irradiation? It may kill my normal cells. Yes, you can be concerned about it. However, it has been this way quite a long years, because although it is not seen and visible, there may be some cells where the recurrence can take place. So the whole breast radiotherapy has been the standard of care. And like 20 years ago, hormone receptor positive or the older patient, or if it's a very early stage, then the irradiation is done only on the partial breast. We now have the results from the trials and the study that the safety of the partial breast irradiation. And there can be one lymph node, and maybe it can move around with the regional lymph node. So sometimes we have to go for like the whole breast plus a regional lymph node. So patients may be concerned if it is not safe, because the irradiation is done over not just the whole breast but also the regional lymph node. However, the regional lymph node has been irradiated for a long time, so you don't have to be worried about it. For whole breast, the partial mastectomy and no metastasis for the lymph node, or small number of lymph node metastasis. When I say small number, it means like lesser than 3 axillary lymph node. Maybe the standard would be a bit different from one hospital to another. If there is one or two, but if the characteristics are fine, seem to be fine, then they just go for the partial breast. But if the number, even when the number is small, but still it seems to be more risky, then they go for whole breast and plus regional lymph node. So the pathological characteristics and the surgical history of the patients are considered. So radiotherapy is done every day, 5 days a week. And the number of the therapy is different from one hospital to another. For whole breast irradiation, it can be like 5 times and up to 30 times. After BCS, there is no tumor visible, but still we want to control invisible remnant tumor. And we have a certain dose to control it. So sometimes it can be done with small number of the irradiation, or sometimes it can be done with a higher number of the irradiation. It's like you are having one pizza, but you can have 8 slices or 4 slices. 8 slices with small pieces, but 4 slices with large pieces. And there has been a study about it. 2 do not have that much of a difference. So the frequency of the radiotherapy itself, or the number of the radiotherapy, does not make that much of a difference. So even if you are receiving small number of the radiotherapy, you do not have to be worried about. At the same time, even if you are having more number of the radiotherapy, you don't have to be worried about it. And after the whole breast irradiation, we do some boost therapy. Maybe it can be called differently. We call it as the intensive irradiation therapy, from like 4 times to 8 times. So we do it together. So for the technique for whole breast irradiation, some patient community, you will see like intensity modulated radiotherapy or three-dimensional radiotherapy. When it comes to the technique, they're quite similar. Which technique is used is decided depending on how wide we want to irradiate at the time. So here you see the whole breast, left breast. The red area is the one where we want to have 100% dose. Whether it's a three-dimensional or IMRT, you see the areas, the total area of the irradiation are quite similar. When you have the IMRT, you see more scattered dose and irradiation. So radiation dermatitis can be reduced. However, the treatment outcomes are not different. So whichever technique you use, there is not much of difference. Here, maybe it's old age. In other countries, it says older than 50 years old, and small size tumor, and negative resection margin, and hormone receptor positive. That can be a good candidate for the partial breast. There are 3 techniques. Here, the source is inserted with a needle, which is called the interstitial brachytherapy. And also during the operator, we can do some intraoperative radiotherapy. And also we can do external beam radiotherapy, something that we do routinely. Here in Korea, interstitial brachytherapy is not much done. However, it is done by many institutions in other countries. And as I said, we can do regional lymph node radiation along with the whole breast. If there is more than 4 axillary lymph node, even if there is only one axillary lymph node, if there is a risk factors, then we can go for it. And for the regional lymph node irradiation, as I said, we are not just managing the visible tumor cells, we are also make predictions about the metastasis. Usually the axillary lymph node is important, and supraclavicular node and internal memory lymph node are important. The invisible tumor need to be reduced in those areas in order to stop the potential metastasis. There are also different techniques, IMRT or 3D. As I said, the treatment outcomes are not different, but when it comes to the side effects, they can be a bit different. And you know that the patients have different conditions, so we need to decide whether this patient is better with the T3D or these patients is better with the IMRT. And for the boost RT, we call it intensive therapy. The name can be different from one hospital to another. Why do we call it as boost? It's because it is done after the primary radiotherapy, or it can be done along with the primary radiotherapy. It is to prevent the recurrence. Not much of a difference here, 3 times or 6 times. Cycle of the radiotherapy can be done after the whole breast radiotherapy or along with the whole breast radiotherapy. When it comes to the side effects, there are some categories, about 5. One is radiation dermatitis and lymphedema, and Sometimes we see some pneumonitis from radiation, also CV complications and bronchial plexopathy. For the first two categories, they can take place sometimes, but the other three are very rare. For radiation dermatitis, most of the patients experience this dermatitis, but the intensity would be a bit different. As you can see here in this picture, you see some darkened skin. So that shows the dermatitis. And next one is the lymphedema. So it's not just about the irradiation, meaning that there can be other causes. Let's say if you have like the chemotherapy or if you have advanced disease, so that you have the more radiation in lymph. So it can cause more lymphedema. So rehabilitation specialists and the radiation oncologists need to work together. And if there is any need for the rehabilitation, we refer the patients to the rehab specialist. For the radiation pneumonitis, you see here that the irradiated area, you see some signs of the pneumonitis. But it's really rare. It's just a 1% of the patients may experience this side effect. And actually, another speaker will talk about how we manage these complications. So as a summary, after BCS, post-operative RT or radiotherapy is a must. And when it comes to extent and dose of the radiotherapy, it should be decided depending on the disease status and the patient status. And the radiotherapy is not a risky therapy. I often say to my patient that radiotherapy is safe. And that's, I think, 80% of my job is to say things like that so that make my patients not concerned about the radiotherapy. Thank you.